Hello everyone, a very good morning to all of you. So we are going to talk about the recall questions in NEET MDS 2025. Okay, so we are going to kickstart with periodontology. So I'll be explaining the questions as sometimes the question might be accurate, sometimes it might not. So these are all the questions given by the students, and the framework, the overall framework might be right, but sometimes the framing of the question might be might not replicate the exact thing what you saw in the screen. Okay. So reading of the first question. So what happens to the mucogingival line or junction as the age progresses? Okay. So let me tell you a few constant structures which is present in your oral cavity. Okay. So mucogingival junction is one of the constant structure. Cemento-enamel junction is one of the constant structure, and sometimes your alveolar crest is a constant structure. Okay. Although it changes with pathology, sometimes it might act as a reference line. Okay. So let me tell you a few significance of the mucogingival junction. Okay. See, you can see a clear demarcation, right? A clear demarcation. That is what we call it as mucogingival line. Okay. So below the mucogingival line or junction, you see the alveolar mucosa. Okay. There is alveolar mucosa, and also the mucogingival junction or the line, it is helpful to determine the width of attached gingiva and width of keratinized gingiva. Okay, so if I measure the distance from the gingival margin to the mucogingival line, that is called as width of keratinized gingiva. So if I minus the probing depth with this width of keratinized gingiva, I'm going to get width of attached gingiva. Say for example, let us assume my probe enters till here. Okay, so let's assume it's 2 mm. So what I will do is width of attached keratinized gingiva, say for example it is 7 mm. So what I will do, I'll minus 7 with 2, then I'll get 5 mm. So 5 mm will be my width of attached gingiva. So mucogingival junction is helpful in determining the width of attached gingiva, width of keratinized gingiva, and below that you have alveolar mucosa. Okay, so as you can see in this picture, the width of attached gingiva or the gingiva might look pale, whereas this portion of the alveolar mucosa is pink or it is red in color. Why? Very simple. See, the alveolar mucosa, okay, it has more of elastic fibers. One. Two is very important thing is this alveolar mucosa is non-keratinized. What do you mean by non-keratinization? Non-keratinization is the layers of epithelium will be only two. You will not have stratum corneum and stratum granulosum. So only two layers of epithelium. So am I right in saying that the epithelium will be thin in alveolar mucosa because it is non-keratinized, only two layers of epithelium, the epithelium will be thin. So when the epithelium is thin, below the epithelium there's going to be connective tissue, right? So the underlying connective tissue is going to get projected more. So the connective tissue has numerous blood vessels. So that is why it appears more pink or red in color compared to the keratinized width of keratinized attached gingiva. So when I say the term keratinized, it means it has four layers, right? Basal, spinosum, granulosum, and corneum. Okay, so we'll talk about that in depth in later classes. So as of now, you just know that because of the keratinization, it is paler in color, and because of non-keratinization, the alveolar mucosa is pink in color. And because of the elastic fibers, whenever we give an LA, the alveolar mucosa swellens, it swells up, right? That is because of the elastic fibers. Okay, so the answer for the first question will be it remains constant. Okay. So now moving on to the second question. So there was a question asked regarding the free flap. Okay. So I'll tell you two terminologies. Okay. Free flap or free gingival graft. Both are different. Okay. If the question was regarding free flap, it simply refers to a full thickness mucoperiosteal flap. Okay. A full thickness mucoperiosteal flap. So where I'm going to give interdental incision and sulcular incision. I'm going to raise the flap, debride it, remove the granulation tissue, switch it back. So approximately 1 to 2 mm of bone can be exposed with a simple full thickness mucoperiosteal flap. Say for example, modified flap operation or Kirkland flap. Okay, so in these kind of procedures, what I'm going to do, I'm just going to give interdental incision, circular incision, raise the flap, debride the area, suture it back. This is called as free flap technique. What is the disadvantage? See, when I have more deeper pockets, I cannot access it. And one more thing with a very important thing about free flap is it should be sutured back to the original position. Okay, it should be sutured back to the original position. So imagine if I'm having a pocket of 8 mm, I cannot raise the flap properly with a free flap. Okay, there are a few disadvantages of free flap. I cannot do osseous recontouring, deeper pockets I cannot access. Okay, now what do you mean by a free gingival graft? Okay, free gingival graft or a pedicle graft. What is the difference between a free gingival graft and a pedicle graft is, when I take a piece of tissue, and graft it completely somewhere else, piece of skin, tissue taken from the hand, grafted in the cheeks region, that becomes a free graft. Okay, so when I displace the graft to that adjacent portion, that becomes a pedicle graft. Coronally advanced flap, apically repositioned flap, laterally repositioned flap, double papilla flap, transpositional flap, bridge flap. All these, I'm just displacing the flap adjacent coronal or apical. That becomes a pedicle graft. Whereas free gingival graft, connective tissue graft, all these taken from the palate, I'm just cutting the entire piece of tissue, taking, placing in the area of recession, suturing off. That is called as free gingival graft. Okay, so free flap is this. Free gingival graft and pedicle graft is perioplastic procedures where I'm completely taking the tissue, placing it in one region, suturing it off, or I am displacing the tissue to the adjacent sites. Okay. Okay, moving on to the next question. This question is regarding halitosis. Okay, so I'll not read out the complete question for you. I'll just read out the key aspects of it. So patient complains of bad breath despite maintaining proper oral hygiene, and the organoleptic score was 1. So there was minimal white coating on the posterior tongue, and also the patient appears anxious and insists that the others to avoid talking to her due to the smell. Okay, there is no systemic cause, and the other parameters are within normal limits. Okay, so what is halitosis? Halitosis is the clinician noticeably appreciates the malodor. Okay, so there is something called as genuine halitosis. Okay, there is something called as genuine halitosis. What do you mean by genuine halitosis? This is the form of true halitosis. This is the form where the patient will be having certain factors that is responsible for halitosis. Genuine. Okay, so in the genuine, it can be physiological or pathological. Okay, so if you take physiological, can be morning bad breath, eating onion or garlic, fasting. All these will come under physiological. This is completely reversible. Okay, pathological. Pathological is, say for example, it can be of intraoral or extraoral. Okay, so intraoral can be of periodontal diseases, tongue coatings. Extraoral will be systemic diseases like diabetes, GI problem, and liver diseases, or any kind of respiratory infections. Okay, so these are all the few causes of halitosis, genuine halitosis. There is something called as halitophobia. There is something called as pseudohalitosis. What is the difference? This is a very confusing terminologies. These two are very confusing terminologies. But after watching this video, you are not going to get confused. Okay? See, pseudohalitosis is – patient comes to the clinic or the hospital for the first time tells you that he or she is maintaining good, brushes twice daily, but despite he or she is having some kind of, the bad breath problems. When I look into the patient, I couldn't find any or very minimal plaque and calculus, which is not sufficient enough to cause halitosis. Very minimal tongue coating, okay? And when I look at organoleptic rating, I got very less scores. I'll tell you what the scorings of organoleptic rating later. So these kind of patients are called as pseudo-halitosis. What I will do is, okay, I will respect the patient the first time, I'll do scaling, I'll instruct, I'll give assurance, send the patient. That's fine. Pseudo-halitosis, patient comes for the first time, we do scaling, give assurance, send the patient. But if that patient comes again and again and again, despite giving treatment, that patients will be categorized as halitophobic patients. What is the treatment? Psychiatric counseling. Okay, patient comes the first time, no as such positive signs, do scaling or reassure the patient, send off. This is mainly because of social anxiety. And if the patient comes again and again despite of treatment, then that becomes halitophobia. So that needs psychiatric counseling. Okay, so I'll tell you one of the very important, the gold standard to measure halitosis, organoleptic rating. Okay, it starts with 0 to 5. Okay, 1, 2, 3, 4, 5. So 0 is no malodor. 1 is very barely noticeable malodor. Okay, 2 is mild, but definitely there is some malodor. 3 is moderate. 4 is more than the moderate, that is strong malodor. Okay, 5 is extremely foul smelling malodor. Extremely foul smelling malodor. So see, when the patient is tells you about malodor, the first thing that you should do is we should evaluate whether the patient is having local factors. Okay, so sometimes there are 80% of the times the malodor is because of tongue coatings. So you should make sure those kind of things are not there. And the organoleptic rating, what is the procedure is, the clinician should smell the patient's breath at a distance, at about 10 centimeter distance. Okay, so the clinician sits in front of the patient, smells the patient, sniffs the patient. So that is what is organoleptic rating, and it is gold standard. Okay, so now moving back to the question, I see organoleptic rating score of 1, so that is no malodor technically, and also the patient is maintaining good oral hygiene, and also there is minimal white coatings. So the patient comes for the first time, minimal coatings, organoleptic scoring 1, no systemic diseases. So I'll go for pseudohalitosis. Okay, same question. If they have asked, like the patient comes and with multiple times despite treatment, those keywords, I'll go for halitophobia. So the answer for this question will be pseudohalitosis. Okay. So the next question. So which of the following drugs is commonly associated with gingival hyperplasia? Okay. See, the term gingival hyperplasia, I won't, vouch for this term, because the term hypertrophy will be more suitable. Okay. So, see, when some kind of growth is taking place, when some kind of swelling is taking place, there is going to be increased production of some cells. Or when a cell is secreted more, there is going to be increase in size. It's obvious, right? Okay. Now, I'll tell you very, very simple 2 mechanisms. I'll talk about in depth when I take separate class on gingival enlargement. Okay. I'll tell you very basic 2 mechanisms of gingival enlargement. Okay. So, gingival enlargement, if you see, majorly it is by 2 mechanisms. One is there is going to be increased fibroblast. And 2 is there is going to be decreased collagenase enzyme. It is self-explanatory. What is fibroblast? Fibroblast is a cell that secretes collagen. Of course, fibroblast will have dual function. It also kills collagen by phagocytic action. So in this case, it is going to produce collagen. So there's going to be increased collagen production. And there's going to be decreased collagenase. What is collagenase? Collagenase is an enzyme that destroys collagen, isn't it? So when a cell is not destroyed, or when a cell is only secreted, what will happen? There's going to be increased amount of collagen. So what is collagen basically? Collagen is an extracellular matrix. It's a fiber. Predominantly, we see type 1 and type 3 collagen fiber. So when there is only production of collagen, obviously the size is going to get increased. So these are the two basic mechanisms why gingival enlargement takes place. Most of the times, all the drugs acts on these two. Okay. So I'll tell you the common drugs. Okay. So first will be immunosuppressants, calcium channel blockers, and anticonvulsants. So immunosuppressants, cyclosporine, calcium channel blockers, nifedipine, amlodipine, verapamil. Anticonvulsants will be phenytoin, valproic acids. Okay. So moving on to the question.